training in the Department of Internal and Oncohematology Medicine. I want to thank the scientific committee for giving me the opportunity and the chance to be present. I am Bouchnafati Sana.
To come, so she will present chronic myeloid leukemia in Aya population. Sana from Internal Medicine and Oncohematology Department, University Hospital, Hassan, Fes, Morocco. Shall we start recording?
I am Bouchnafati Sana, a medical training in the Department of Internal and Oncohematology Medicine. I want to thank the scientific committee for giving me the opportunity and the chance to be presenting our work today, which is about chronic myeloid leukemia in AYA population. I would like to start by setting up the definition of AYA, which is stands for adolescent and young adults between the ages of 16 to 39. The incidence of malignant diseases in the AYA population, adolescent and young adults, is on a steady increase, and the chronic myeloid leukemia, classically described as a disease of the elderly patient, is no exception. Aim of this study, we aim to assess the prevalence and characteristic of this pathology in this age group. So for this study, it is a retrospective study, descriptive and analytical, about 171 patients with chronic myeloid leukemia followed up in our department between January 2012 and December 2022. AYAs were defined as those between 16 and 39 years of age. We had as a result, as epidemiological results, numbers of cases were 55 of AYA's patients of 171 patients. Median age was 29.45 years old. The sex ratio female-male was at 1.11. And unfortunately, for the diagnosis delay was high and was about 4 months on average. The performance status, 25%, and splenomegaly was presented in 92.7% in our population. For the in the initial biological results, anemia was in 85% and peripheral blast in 49% of our patients. Major hyperleukocytosis was defined as more than 100 giga per liters and was presented in 65.5% of our population and syndrome tumor lysis in 60%. In this study, we have found a significant association between AYA group and the presence of major leukocytosis and anemia and tumor lysis syndrome. For the myelogram in our AYA population was categorized as a chronic phase in 70% of our patients and accelerated in 29% of our patients. And BCR-ABL was founded and is detected in all our patients. For the therapeutic management, we had to initiate with hydroxyurea in 65% of our AYA patients prior to initiation of ITK treatment to reduce cellularity. And imatinib is the first-line therapy in all our patients, and the response was 81.81% of patients. Nilotinib was just used in a second-line therapy in 80% of our patients. For the evolution, unfortunately, we have lost 11 of our patients. We sadly lost 11 of our patients. 8 developed acute, 10 10 of our patients, 8 developed acute myeloid leukemia, and 1 died of cerebral hemorrhage, and 1 of septic shock. For the Kaplan, we can see the difference between the two curves in the Kaplan-Meier survival curves between the two groups, AYA and adults, and we can see in the AYA group, it was the overall survival at 5 years was 83%, and for the adults it was 92%. There was a significant association again with AYA group and death. A lot of studies were interested in this subject, and we find ourselves in comparison of epidemiological and clinical features. But the treatment with imatinib as first line was only used in about 50% of patients, which was not the case not the case in our study in our department due to the non-availability of other therapeutic options, which might also explain with an elevated diagnosis delay the overall survival, which was in our study 83%, and in Calmanti et al., they reached 97%, and in Pemarajo et al., 93% of overall survival at 5 years. So this poor outcome, though unexpected but seemingly true, should encourage us to look for the underlying genetic and environmental causes and take this challenge on board while treating CML. Thank you. And this is our team, which supports me forever and always. Thank you.
Thank you, Dr. Sana. And